Broadcast is now starting. All attendees are in listen-only mode.
Okay, great. Good afternoon, everyone. Thanks for joining us for this second coaching call of the Boost Collaborative. We're just waiting for a few more people to join, but maybe I'll introduce myself. So this is Laura Beamish. I'm the project lead for the Boost Collaborative. A lot of you I've met in person and had meetings with, and we're really pleased to have Jen Block joining us today to give some of her wisdom to some of our team members and her experience with the Stop HIV/AIDS Collaborative, and also some of the work that she's currently doing implementing OAT in a clinic in Courtenay that she's working at. So maybe what I'll do is, we have a good number of people on the line now. So I'm going to pass the ball over to Jen here, and she can introduce herself and tell us a little bit more about the work that she's doing.
Hi, everybody. I hope you can hear me okay. So first of all, I haven't actually done a webinar before, so please thank you for your patience, and hopefully it makes sense and there's enough time to answer or to ask questions, and hopefully it's useful. So Laura asked me to talk about implementing quality improvement into practice based on the work that our team, Positive Wellness North Island, which is a Hep C and HIV program that was involved in the Stop HIV Collaborative, has sort of done over the last number of years, and sort of give some examples, and then maybe some learnings, share some learnings that we've had from our project. So like I said, our team is called Positive Wellness North Island. We are North Island Liver Service and North Island HIV Service. Essentially, we provide care for people in the North Vancouver Island who have hepatitis B, C, and HIV, as well as folks who are at risk of contracting those viruses. Our team started as a collaborative project with a partnership with AIDS Vancouver Island and the Mental Health and Addiction, Mental Health and Substance Use Services now, which are part of Island Health. We have registered nurses and nurse practitioners. We work with physician specialists, gastroenterologists, infectious disease specialists, and internal medicine specialists. And of course, we have our admin team that we couldn't really function without. Our region is the second red line up. So our program covers the north part of Vancouver Island. My local team and the place where I work is in Courtenay, in the middle of Vancouver Island. So we started with the HIV Collaborative in 2011, prior to us actually being Positive Wellness North Island. Like I said, we were collaborative between AIDS Vancouver Island and the North Island Liver Service. We saw a need we perceived that there was a need in our area for more local HIV care. And so we wanted to see, what we could do. And so we got involved with the collaborative as supported by our leadership. And so we tried to figure out what quality improvement was. Actually, not a lot of us had experience with it. And, so we learned about our aim statement. So what are we trying to do? How were we going to do it? And how we would begin to measure those changes that we were trying to make. Along the way, we really thought, so how did we get into this? It was really a challenge for us to talk about our practice, and I think that's quite common. To talk about our practice in front of a lot of other colleagues was a bit daunting, but really meaningful. We had to create a lot of tools to help us along. We had to use a new database, which was also challenging, and have more meetings. That's what this slide is about. Sort of our internal versus external voice. This is an example of one of the aim statements that we came up with in 2014. So you can read that, but essentially we wanted to increase our outreach activities to try to have more success reaching people that weren't actually connecting with our program. We had to specify the populations of focus that we were doing that with. And then we had our outcome goals. I'll just give you a minute if you want to actually read that. I'm going to show you examples of the second and third outcome goals. So the second is to increase the number of people with HIV who are linked to care who were previously lost to follow-up. Historically in our region, there was no local HIV care, so people had to travel. And if you live on the north of Vancouver Island, that's quite a long journey to Vancouver. Many people went to Vancouver for their care, or in fact said they went to Vancouver for their care, but most actually didn't make it over for a number of reasons, including the distance, the time away from family, the cost, and the risk for some of them of going to Vancouver. So when we started our program, this shows the time at the bottom and the actual people who we were. So we started it not as an HIV service. We started, like I said, as a liver service in AIDS Vancouver Island. So we had people that we knew had HIV. And then when we started our program, we advertised that this program was beginning. We talked to all the physicians in our region. We talked to our partner agencies. We let some positive folks know that we were doing this. And what we found over time is that we weren't really connecting with a lot of people. Those folks who transferred into our care, that was fine, and some new diagnosis, but the connecting with those people who were still out and about and not connected to care was tricky. So we wanted, again, in our aim statement, to increase the number of people linked to care. So we started our outreach, and what we found over time, and this was a slow, as you can see, there's actually not that many people involved at this period of time, but slowly but surely we did connect with people, but it took a long time. We didn't necessarily, when we started the collaborative, understand that some of our PDSA cycles and some of the goals that we had were short-term, and some of them we thought would be shorter term actually turned out to be longer term, which was something that we didn't quite expect because we were doing rapid cycles, but some of the work that we started on actually translated into longer process. So one of the other goals from our aim statement was to increase the percent of people who were getting their viral load tested. So we knew from the data that we were collecting that we had a fairly significant amount of people who weren't getting their lab work done. We could tell from our electronic health record and from them actually just not going to the lab, blatantly telling us that they weren't going to the lab, that they weren't. This was a gap. So we wanted to try to do something about that gap. This was actually a long also period of time. We wanted to, so in the early part of 2016, we looked at our database and we saw that under 70% were getting their blood tests done every 4 months. There were lots of good reasons for this, but that was one of the things that we have to report on in our program. So it was something that we needed to address. We decided as a team, like I said, to address that need by doing outreach. And for us, outreach, because our program, unlike I imagine some of yours in Vancouver, we are regional, and so we don't have a population of focus that is anything other than the people that live in our region. So we had to look at our regional outreach. We went to the methadone clinics. We started going to the methadone clinics, which we're still doing now, to connect with people who would show up to those appointments. We went to some of the places where people were camping out, some of the shelters, the First Nations health centers, the harm reduction, needle exchange, soup kitchen, partnered with some of the other agencies to just see if we could connect with people, and maybe that would make the difference that we were hoping, sort of getting them connected and following up with their primary care stuff, in this case, getting their blood work done. So we measured again for the second quarter and found out that outreach didn't actually do much to make a change in what we were trying to accomplish. So I wanted to show you this because it was an important thing for us to learn that some of the tests, or some of the PDSA cycles, or the tests of this change, are like, you might try something and it might not work, even though you put a decent amount of effort into it and think that it's a really good idea. You may find that that it actually doesn't do anything, which is what we found out. We were able to make some progress around relationship building and sort of maintaining a presence, but it wasn't actually achieving what the particular aim statement that we had. It wasn't wasteful. I think it was definitely beneficial, but it wasn't impacting the way that we were hoping. So along with the outreach, we decided that we had to tweak it a little bit, that while we were doing outreach, we could also actually do the blood draws, because we're registered nurses. We some of us had to do some extra training and then make connections to the lab and work out ways of actually making this process manageable. But we, over time, and it wasn't quick, even though it seems like it should be fairly straightforward, we started doing that with our outreach as well. And then we found that we did actually make an improvement. And this is something that we've, so this was kind of like an experiment, trying to see if this would be something that would be helpful. And it turns out that, yeah, it is helpful. We've made a difference. And there are some folks that we work with now that this is just what we do with them. It's sort of integrated into the services that we provide for them. It's definitely not everybody, and it's focused on those people who needed that extra support, and they do find it to be really helpful. We also had some questions for ourselves around the connection to care. So I'm sure you're familiar with the cascade of care, and I know that you have like a cascade of care for connecting with the people and making the changes that you're working on in your teams right now. Our cascade of care led us to be curious about people's connection. So we knew that we were providing this service and that we were changing how we did things, but we wanted to know what the people thought. And so when we were entering the collaborative, actually prior to entering the collaborative in 2011, we did a survey of people in partnership with AIDS Vancouver Island who were positive. So we surveyed about 17 people just in our region who we knew were positive and asked them some questions. We repeated that same survey in 2016 to a few more people and some different people. So it's not a exact comparison, but it's people's self-reports in 2 snapshots 5 years apart. So one of the questions we asked was, do you have a regular doctor? And in 2011, almost 20% did not. And in 2016, actually one person didn't. So out of the 25 people, only one remained to not have a family doctor or a nurse practitioner. This was significant for us because that was one of our beginning aims, was to sort of see how we could make services work for people who we were following and make sure that they were feeling like they were connected. And so with this self-report, it was interesting to see that they themselves reported being connected. We also asked them if they had an HIV specialist involved in their care. Some of the people that we follow still see specialists in different communities. They live in this community, but they go elsewhere for their specialty care. Most of the people we see do see the infectious disease specialists that we work with here. So in 2011, you can see 17% did not see a specialist. It's important to also know that the 82% that said yes, a significant amount of those people actually didn't see the specialist. They may say they saw Dr. Hall in Vancouver, but they hadn't seen him for the last 3 years, but they still counted him as their specialist. In 2016, out of the 25 people we surveyed, only one said that they didn't have a specialist in care connected to them. So we were also pleased to see that. We also asked them to rate their physical health in the last 12 months. This quality improvement measure was something we struggled to actually try to elicit from people over time. But we struggled to kind of work out how we were going to do that. We had different kinds of surveys. People didn't like doing them. Quick kind of even incentivized data collection things didn't work super well for this population of people that we saw, but we did make the effort to do the same survey that we did in 2011. And from that, we noticed that, in 2011, nobody said their health was excellent versus 2016, 12% said their health was excellent. In 2011, 40% reported having poor health, and that really decreased in 2016. We don't know if this had anything to do with us, but it was, again, just a self-report of some folks involved in our care, which was interesting and related to quality improvement, actually encouraging to our team that we felt like we were making some changes that were making a difference for people's lives. Some of the things that we learned along the way in our quality improvement journey, I suppose, that we're still on, were to keep the change, to keep it simple, make small steps, and be consistent. We had a number of grand ideas that were really hard to get off the ground and kept having to come back to, what small steps can we make that we can actually do and see through to the end. We had a number of people in our team who were quite ideas thinkers, so we had to kind of temper what we were trying to accomplish. We had to stay curious, and we had to keep asking questions about what we were doing, about the systems that were in place, about the people's what they said they needed. We had to keep asking, how are we going to do this? When can we possibly fit this in? Is this important right now? Should this be something that we should, wait a while to do? We had to continue to collaborate with different providers to try to connect with people. We had to build relationships with people who were with service providers who were used to working on their own, and now we've, made some really good partnerships and collaborations around supporting the people that we work with to access and connect with care and get their needs met, essentially. We learned that it was really important to use a strengths-based approach, which is something that we're really used to using when we're working with people who are coming to see us, and that we were less used to using as a team in our work with each other. So we, instead of looking at things from a problem perspective, started looking at things from a strengths-based approach, where we could see, okay, what can we do? We're really strong in this area. How can we leverage the strengths that we have? We learned a lot from other people who were doing similar work, especially being involved in the collaborative opened up a lot of opportunities to learn from other teams, maybe that weren't the same as us or even focused on the same kind of population, but it really helped to hear what other people were doing and apply that to what we were trying to do in our team. At the same time, it was really beneficial to share for us to share what we were doing and what we were learning, not only with the other teams in the collaborative, but really locally. For example, we started on our program doing outreach to certain places. Many of the other services don't provide outreach. They expect people to show up to an office kind of based setting, and we knew that that really wasn't working for people who could take advantage of that type of service. And by showing what we were doing and by encouraging other people to just try it and see what would happen, that has shifted other agencies' practices, which was pretty cool. Like I said, we had to take small steps, really importantly, and also be consistent. As soon as we kind of backed off, we would, it's kind of easy to keep just doing what we're doing rather than keep that curiosity going, stay consistent with wondering what we can do next to improve what we're trying to accomplish. And so taking small steps and being consistent with that and building a system around our team to sort of encourage us to keep that going has been really helpful. We used to have every meetings as a team every 2 weeks to sort of keep this rolling. And eventually, over a couple of years, we realized, well, once a month should be fine. So we had our meeting once a month. And presently, we meet every 2 months. We still, and we interact differently over time. We're better with our framework of quality improvement. We still need to remind one another that, we do have a focus and, what are we doing around that? But the consistency has been really important for us. We had to build our confidence with this and realize that some changes were easier to make. When we made some smaller changes, we were more confident in being able to, continue, that this was something that became important to us. At the beginning, we were more hesitant and unsure. There were some really important system level lessons that we learned. First off, is that quality improvement can be difficult. This is a shift in practice, and it requires support in the team, but also system support, because it's a different way of doing work. I mean, we all know that healthcare is really task oriented, and this can be task oriented, but it's really stepping back and looking at things from a different standpoint. Another system lesson that was, it still remains challenging for us is that the data collection and analysis takes time. We don't have good data collection system. Well, we had to create a new database, in fact, but we don't have an electronic health record that we're using. That is a definite challenge. Hopefully, some of you have really good electronic health records that will support your work. That will be easy to pull what you want to look at and reflect the work that you're doing. Without those systems, it's definitely challenging. We learned that quality improvement has the opportunity to build accountability into the healthcare system, and this was really important to us. Because we wanted our service and the healthcare system to actually be more accountable to the people who are accessing services over time. A lot of the people that we work with experience stigma in the health system. They experience challenging accessing care sometimes, and so we wanted to use quality improvement to sort of build in some accountability, and it is possible. A challenging aspect of asking questions over and over again is that sometimes you get answers that you don't really like, and the answers about things that you'd like to change can be really daunting. taken turns in our team of, you know, actually being quite distressed around some of the stuff that's coming up around working with the population, and our role as part of the health system in that. So it's important to keep asking questions, but sometimes it's difficult as well. I think most importantly, leadership support and champions in this work to keep you going in this work are really important. We would not have been able to do the work that we do without the clear and dedicated support of our leadership among sort of all different levels. So that is something that really sort of allows you to be creative and take the time that you need, and also hold you accountable to the changes that you said you were going to make. Does anybody have any questions? I should have said that at the beginning. If you do have questions, just type them in, and Laura can manage them, and we can, you know, have time to answer them too.
So Jen, we just did have one question come through, and that question is, what helped you protect time to work on your quality improvement with your team? I think, yeah, what strategies did you use?
Yeah, what really helped was establishing the meeting time where we all committed to coming together to focus on that work, and that did change over time with the frequency and the amount of time. At the beginning, we had to spend more time meeting together, and that's where the support of our leadership to tell us, like, this is really important. We know the other work that you're doing is really important too, and we want you to take the time to focus on this. So we were basically encouraged and told that we must do it. And then as a team, over time, once we got more comfortable and we're making some more progress, we review that yearly, and then we've decided that we can do, we've changed the structure of the meetings, we've changed the location, we've changed the amount of time that we need, but actually keeping that protected was really important. One of the things that we also did the last 2 years was we separated into sort of geographical teams, and those teams meet on a weekly basis to discuss some of the quality improvement and actually client review things. So that became part of the system that we established to make sure that we protected that time to be able to continue the things that we were supposed to do. We kind of have to commit to it, just make it happen. Otherwise, at least for me, that will fall off the side. I'll just, again, it's that task sort of stuff. I'm busy, I have plenty of things to do, and meetings are one of those things that I don't really love. So unless, like, I've committed to the team is accountable to one another, it can be easier to kind of, slide off. But because we've made that into a system, and we are really accountable to one another as team members, it's easier to protect and make sure we're doing it.
Great.
Does that?
Yeah, there was one follow-up point was how long your meetings typically are.
Right now, we meet every 2 months, and our meetings are 2 hours. When we were meeting, at the beginning, we started meeting every 2 weeks, and I think the meetings were 2 hours. So over time, they've decreased. Once a year, we have a planning meeting that's a whole day, and we sort out we review our planning from the last year. We review our goals that we set, we review the data that we've collected, and then we make our plan for the coming year, and what are those things we're going to focus on, and then make a strategy to sort of do that. Those planning meetings then fall out into how are we, so this year and last year we have these geographical check-ins where we continue to do those, to check in with each other and update each other on those things that we said that we do from the planning meeting, and then we'll report back on those we do them in the new year.
Great, that's great. And so if there's anybody else who has questions, there's a little question box on your control panel. So just type them in, and I'm here sort of moderating as we go, and I'll interrupt Jen if there's an urgent question. So feel free to ask questions as we go.
Okay. Okay, I'll keep going. I just talked a little bit about this, but the aspect, one of the other things that I think we had to learn over time was like teamwork and change has its whole own dynamic. And it was really helpful for us to kind of identify, you know, amongst the team, who's the systems thinker. We have a couple of people on our team who are really strong systems thinkers, who look at things from a really big picture perspective and see like where we can make links with other folks, and they're really good at looking at that broader perspective. We have someone who's a real data person. They have the data collection brain. They are really interested in it, and they keep us focused in that aspect. We have people who I will call the disruptors. They challenge us. They ask hard questions. They ask questions about, you know, the way we're doing things and why we're doing them, and, you know, sort of disrupt the status quo. And they're really important to listen to too. The champion. So who's the kind of cheerleader? And in our team, we take turns, you know, because there's a real flow and an ebb and flow to this work. Like sometimes someone will be a champion, and then, you know, they'll become less interested or quite like not so excited, and someone else will take up that role. So we try to use each other's strengths. We had to learn what those strengths were, and then use those strengths as we're sort of moving along in our with our team, with our, you know, quality improvement project. So I guess I'll say, again, we had to build confidence for change. You know, we talk, our team is really comfortable with change. We do change kind of all the time, but sometimes we're tired of change, and there's lots of changes that come to us, say from IT or from new systems that are put into place that we don't have any say in, and so we have to kind of back off sometimes with our own little projects when we feel overwhelmed by these other changes that are kind of coming at us. So that's important to I think that's important to take into consideration. We, you know, we have lots of discussion around what matters to us. You know, different people are really sort of feel strongly about certain topics, and certain things are really important to them. We talk about these things. So what matters to us, and then what are we going to do about them? Most of those things are related to what people tell us are important to them, the people that we're trying to serve, the people that are coming in, and the people who actually don't come in, who we see on outreach. So we try to integrate that into the changes that we're making. We're really fortunate in our team that we are able to challenge each other. We've built these relationships. We trust one another enough that we can challenge our viewpoints. We can challenge our ways of doing things. We can have really lively discussion and ask lots of questions, which has been such a, I really think, a gift and really encourages us to be flexible, to be creative and innovative, and sustain the support amongst one another that it really takes to do sort of more challenging work with sometimes more challenging population. And we've really had to, you know, keep our goals in mind and keep bringing each other back to like why we're doing this. What was the goal that we were going to work on? How were we going to do it? And, you know, that accountability piece comes through there. Like I said, with the, you know, with the benefit of being able to work really closely with our, you know, within our team, having the ability to challenge each other with this goal in mind kind of makes it a safer space, you know, like we have a purpose. And it's been really, it really feels like I'm really grateful for the team that I work in. I feel it's really fortunate. It doesn't happen all the time. Any questions?
No, no ones have come through yet.
Okay, so I'll skip this. I'll just, Laura wanted me to briefly talk about what we're doing. So in my work, I have two different roles. I am a nurse in the HIV and Hep C team, and I also am the team leader or the coordinator for this low barrier health clinic called the Health Connections Clinic, which is in Courtenay, and it has evolved over the last number of years in partnership with our Division of Family Practice. We have physicians that work on sessional funding. We have a nurse practitioner, we have nurses, we have our admin team, and we also have really important partners with mental health and substance use, with the chronic pain program, with public health and the Division of Family Practice, among others. So it's a low barrier health center that basically focuses on serving people who don't meet the sort of regular office-based primary care model, right? They're not great at showing up for appointments often in doctors' offices. They might be really complex and have lots of you know, challenging issues. Our population has a high substance use and mental health background. We have sort of a more vulnerable population. I forgot to put in our partners the actual HIV and Hep C program that I work with, but that's also a partner to the Health Connections Clinic. So with the, as you're well aware of, the overdose crisis or drug poisoning crisis that's happening in our province and across the world right now, we saw an opportunity because there was a real gap in our community around accessing opiate antagonist therapy in the Comox Valley. We have just one private clinic that runs 1 day a week that provides people with Suboxone methadone, and they don't do Cadian, but just Suboxone and methadone. So people are concerned, people are afraid of dying, and people have to wait a significant amount of time to get the service, like 3 to 4 weeks sometimes. So we had the need, we have the means. There's a real willingness in our community to collaborate with one another to address this issue. And what I will refer to as the golden opportunity is that we've really got staff here in this primary care clinic who are engaged in offering the service, both the medical staff and the admin, like everybody in the building essentially thinks this is really important. So our aim currently is to improve access to opiate antagonist therapy in the Comox Valley by offering Suboxone at our Health Connections Clinic. That also is going to include methadone and Cadian. The doctors are working on their licenses to be able to do that. But because they're primary care providers, obviously they can do Suboxone right now. So we're, like I said, we have this gap in that there's only 1 day a week service. We have the interest of the staff, and we've have this partnership with Mental Health and Substance Use, who had some physician session funding that they weren't that they would use, but they kind of donated to this project in the short term. So we had the opportunity to do the right thing. We all agreed that it was not something that staff has not done this work before specifically, but that it was, you know, there's definite buy-in. It's important and something that they want to work on. So our next steps in this sort of baby quality improvement project, I guess you'd say, is that we've identified that we need to collaborate with the existing clinic in town to see how we can, you know, enhance the services that are available. we need to integrate people with lived experience into planning and delivery of service. I was really impressed with the team at the very beginning when we decided to do this, and they took some training and they were hesitant to start, but people were starting to show up here asking for it. So we decided that we should just go ahead. And from the very beginning, they really partnered with the people coming in and even said, you know, look, this is something that we're not experts on. In fact, we don't really have any experience, but we've had education. We have some other people with experience that we can, you know, ask to support us, and we're willing to do it. Are you willing to work with us, to partner with us along in this journey? And people were, and they really appreciated that. The feedback that we got from them was that they were everything from them being proud of us for trying to you know, being really thankful that we were willing to work with people that had substance use issues. And as you know, that's fairly challenging in the medical system to find interest in doing that. But we want to more officially integrate you know, the people with actually that are suffering into what we're doing. We need to continue working on support for staff and continued education. We are learning as we go. We've you know, you don't know what you don't know until you start somewhere. So the more they learn about this work, the more they know they need to, the more they realize they need to know. So it's going to be an ongoing process to support the staff to be able to continue this work. And they're really engaged in that. It's really fantastic. We need to advocate for sustainable funding. We are working with leadership at different levels to be able to try to figure out how we can maintain this service. Hopefully that will work. And we need to work on our data collection. So we have we don't have an electronic database, but we do have an Excel, you know, we have like a spreadsheet kind of thing, database. We don't have the electronic health record. We're working on, you know, what data do we need to capture. We're starting with satisfaction surveys. We've actually been doing that in this clinic ongoing over time, but we wanted to sort of focus on making sure that we're asking people about, you know, do they feel comfortable coming? Do they feel respected? Do they feel included in their planning? And then we also are serving the staff and getting feedback from them around working in this way. Any questions?
So I had one question, Jen, come in from Rolando, and his question was, do you have any examples of where you sort of touched on it here, but specific learnings that you took from your time during the HIV Collaborative and applied it to the work that you're doing now? So yeah, examples of your learnings to other areas of your work.
Yeah, at the very beginning, we knew that we had to, because this was kind of like with the HIV Collaborative, we were supported from leadership right away, like to focus on this, we need to do this. And this is a different scenario. We, in our community anyway, have a local working group around this overdose crisis, and that has a number of different agencies and levels of leadership in our island health sort of world. And we knew at the beginning we had to get leadership support, and there were some challenges in that. At this sort of simultaneously, we were also working at building relationships so that we could do this as a collective, which we learned from the other collaborative was really important. So we didn't want to reinvent the wheel. We didn't want to do it all ourselves, but we want to be a part of it. And we knew that we needed to partner with other people. And in this case, one of our biggest partners has been mental health and substance use. And, you know, we're continuing to work out how we can support people to come in to access these services. In our region, as in many others, the people who are most at risk are using a loan at home. They're not super connected to care. So we wanted to try to do things a little bit differently than they're currently being done. So we needed to build those partnerships. On a staff level, we don't have a established, well, we don't have the same opportunity because we've got different ways of paying people, essentially. Like, we've got physicians on sessional time, we have nurses and other staff that are paid, you know, on salary, and we can't all meet at the same time. So we can't have the same structure around the dedication to the work because of the limitations around funding. So we're trying to be creative with that as well and tap into some other areas to really include the whole team in this process. Does that kind of answer the question, Rolando?
I'll see if he types back. Anybody? Oh, yeah, he said yes. Great. Any other questions? If people would find it easier to ask the question live, there's an option to put your hand up, and I can just unmute you, and you could ask your question live if typing it in isn't working, or if you'd prefer to do it live.
Okay. I think we're almost there. I talked about this a little bit before, but it's real. It's a kind of up and down experience doing quality improvement, and this graphic kind of speaks to that to me. You know, like, you think sometimes you have a lot of energy and think this is really going to be great, and then you get into it and you're like, no way, this is terrible, this really sucks, I don't know what I'm doing, and we're not really getting anywhere. But, you know, drawing on the support of your team and your own sort of coping and humor, I will say, is really important. You know, you're able to kind of come back out, but this continues, this kind of up and down really continues, and I think it's really normal. And it is sometimes feels really hard, and other times feels really extremely rewarding. But I just wanted to throw this up here because I think it's normal, and, you know, you can't really be excited about it all the time. But it's not also horrible all the time either. Collaborate. That's my final word to you all. And have fun. If you have any questions, or you want to just ask more specifics or whatever, you can contact me. I'm happy to sort of share some more details around what we're doing. We're not experts by any means, but we are interested, and this work remains really important to us. That's it.
Great. Thanks so much, Jen. That was really great. We've had a couple more questions come through. So I have one question that says, sorry if this was covered earlier. On your OAT days, do you take appointments or walk-ins for methadone and Suboxone?
Right now we take appointments, but we will see people who walk in. So we try to do appointments, but we have we've built in extra time, and the people who come for renewals, we can shift to another provider sometimes, so we can free up some space. So we try to be flexible, because we know that that's a challenge for some people.
Great. Great. And Mari said, awesome work.
Thanks.
So Rolando had another follow-up question about, are you using your quality improvement experience to build the business case for the sustainable funding that you mentioned?
Yeah, we are. Yeah, we are, and we've tried to lay it out like that, which is one of the reasons we've started to figure out what data we need to business case that we're making is that, okay, people are coming here. They've told us that they want this service. We are a low barrier clinic already, and we have the interest to do it. So, you know, let's work with what we have. And that's, you know, one of the reasons we started with the surveys, to sort of back that up.
Great. So then there's one other question about how are you motivating staff who aren't engaged or motivated to make changes?
I think in how we frame it. So I'll often frame it as like, let's try this experiment. And it doesn't, experiment seems less big than some sort of big change. Like, let's just try it out. Let's see how it's going to go. You know, can we suspend our judgment? And, you know, figuring out what's, you know, so if you've got someone that's not super keen, going back to sort of learning about one another's strengths. Like, everybody really has something to offer, and figuring out what it is, like kind of what jazzes the person up and how we can apply that to this kind of work is really important.
Great. Are there any other questions from anyone who's on the line still? Any specific questions you want to ask Jen? I would encourage you to reach out to her through her contact info there if you have any follow-up questions, but maybe I'll wait another minute to see if there's anyone who's got any final thoughts or questions.
Thanks, everybody.
Great. Okay, perfect. So yeah, if you have follow-up questions, please email Jen. You're going to get a survey, an evaluation survey in about an hour from me. So please take some time to fill that out so we can run our own PDSA cycles and improve these webinars to make sure they're valuable for you. But thank you, Jen, so much for your time today and for talking to our teams about the work that you've done. And again, follow up with Jen with any questions, and we'll be seeing everybody on December 7th at the learning session. Great. Thanks so much, everyone.